passionate about hospice, and we love to get the word out. Is that better? I have been a hospice nurse for about the last 15 years. And 14 of those years I did home care hospice, hospice patients that were going to die in their own home. And then about a year ago, I transitioned to inpatient hospice, which Tracy and Dr. V are going to come and talk to you about a little bit later. But before they do, I just want to give you just a little bit of an introduction to hospice and maybe clear up some misconceptions about what hospice care really is. One of the first questions that people will ask me when I tell them what I do is that, how can you do that? It must be so sad. You know, how can you do that every day? And I say to them, you know, it's all how you look at it. Life is a series of goals that we strive to attain and accomplish. And when you find out that you have a disease, your goal is to beat that disease and live as long as you can. But then there comes a point where that goal is no longer attainable. And so then your goal becomes a good death. And that is a goal that we can always reach. And so it's looking at it in a positive way, because it's something that's going to happen to all of us. And we're all heading in that same direction. And dying is a process that often starts months before the actual death. And so a patient or a person may start to withdraw, stop eating, be disinterested in their surroundings, sleep more, and then you know that the disease is progressing to a point where you can understand when is a good time to come to hospice care. Now, the definition of hospice is that you have to be diagnosed with a terminal illness that you are no longer seeking curative treatment for, that with a prognosis of 6 months or less to live. If you live longer than 6 months when you're on hospice, as long as you're declining, that's fine. You don't run out of hospice benefit, which Tracy's going to talk to you about, of which what pays for your hospice care. And there's a lot of myths and misconceptions about hospice. And some of them, one of them is that you basically, when you come to hospice, you have one foot on a banana peel and the other foot in the grave. And really, I think that is just so not true. I think in large part that comes from the fact that when we first started to have hospice in this country in the late 70s and early 80s, you only had a certain amount of hospice benefit, 90 days. So if you went on too soon, you may run out of your hospice benefit, what's going to pay for your hospice care, and then what will you do? You know, you'll have to go to the hospital or something like that. So people did not want to go onto hospice until the last minute. And then finally, you know, we came to understand that being on hospice a little bit earlier and longer keeps you out of the hospital and keeps your symptoms controlled and keeps you more comfortable. And so Medicare changed the regulations for when you could come onto hospice. And it's not only just cancer patients that can be on hospice. Also, it can be heart disease, kidney disease, lung disease, you know, emphysema, that kind of thing. Neurological diseases like Alzheimer's, MS, ALS. These are all patients that can be on hospice care. Another myth is that people think if I go on hospice, I'm failing. You know, a doctor may think it's a failure for him, or a patient may think, oh, you know, I'm failing my family. But in reality, to be able to give your family member the opportunity to die in their own home, or to be able to encourage them to go into an inpatient facility so that they can die with dignity and comfortable, is really a great gift for that person. A lot of people think that hospice is in the business of hastening your death. You know, it's like sometimes when I would go to a patient's home, it's almost like they thought I was the Grim Reaper at the door with morphine in one hand and a funnel in the other, and that was what I was going to do. But really, it's not like that at all. We don't over-medicate patients. We give them what they need to stay comfortable or to treat a symptom. And there's also the misconception that once I go on, what if I get better? You know, are they not going to want me to get better? That's just not true. A lot of times the patient will end up being discharged from hospice because when they come on, they do get better because their symptoms are well managed, and maybe their medication, maybe they're on too much medication, or something like that. So that's another myth. Hospice care is a team approach. There's the nurse, the doctor, the social worker, this chaplain or spiritual counselor, and the home health aide, the volunteer. There's bereavement services. It just covers every area that you can imagine that you may need. The nurse comes in, assesses the situation, speaks with a doctor, gets a plan of care and implements it, and the family is involved in the plan of care. There's no secrets in hospice. So if you're unable to take care of your loved one at home, or if they have a symptom that can't be managed in the home, they would go into general inpatient, and this is where Tracy and Dr. Lee are going to step in. Thanks.
Hi, I'm Tracy Arnauer. I'm the hospice liaison for Holy Name Hospice, and Holy Name Hospice has an inpatient unit. I don't know if maybe some of you are familiar with it. It's called Villa Marie Claire.
Yes.
How many people know what Villa Marie Claire is here? So, just before I talk about Villa Marie Claire, I'm an MSW, so I'm a social worker. That's my clinical background. I'm a licensed clinical social worker. But I do act as a liaison between the hospice program at Holy Name and pretty much all of the hospitals in Bergen County, and then any neighboring county that may want to send a patient onto hospice with us. And Ronnie did talk a little bit about the goal of the hospice program is to keep patients at home and allow them to get the care they need while they're declining from their illness without having to go to the emergency room or having to go into the car and go to the doctor to get a prescription. It's really about bringing the care to the patient, which is a very big help to the family, and there's a lot of benefits to providing care at home as opposed to patients having to be in a hospital if they're in pain. So if you're not able to be cared for at home, you might decide to go to an inpatient facility. Villa Marie Claire is the only freestanding hospice facility of its kind in Bergen County, and really for most of the surrounding counties, there's no other facility like it. It's very unique. Most hospice providers, and there's many different hospice providers in the area, most of the big hospitals have their own providers, so Valley Hospital has Valley Hospice, you know, there's a Hackensack Hospice, Inglewood has VNA. So Holy Name Hospice is very lucky. The nuns, the Sisters of St. Joseph of Peace, donated the Villa Marie Claire to Holy Name to be used as a hospice. That's the mission. It's a not-for-profit hospice. So sometimes patients will start hospice at home, and Medicare is really the gold standard for hospice. Fortunately, most patients, when they're referred to hospice, they are receiving Medicare. They're elderly people. Most private insurances will mimic the Medicare hospice benefit. So if you're a younger person, you're not yet on Medicare, you can still get the same coverage. But the coverage is limited. If you're home on hospice, then Medicare and most private insurances will cover the care 100%. So the nurse will visit you at home, the medications are provided, all the medical equipment, some home health aid hours, counseling support. If you want to come to an inpatient facility because you're not being managed at home, or your family can't, take care of you, or you live alone, whatever the situation is, sometimes Medicare will cover you at an inpatient facility, and sometimes Medicare doesn't. So this is another confusing part about how hospice gets covered. If your doctor refers you to hospice, because you have to have a doctor's order in order to be admitted to hospice, the doctor will send the order to Villa Marie Claire or another hospice, and then we do an evaluation to see what is your level of care. If you meet routine level of care, then that means that you're able to be managed at home, and all your care is covered by Medicare. If you meet GIP level of care, that's general inpatient hospice. That means Medicare agrees that it's medically necessary for you to be in an inpatient hospice, and Medicare will cover you 100%. I will usually go out and meet patients when they're referred to Villa Marie Claire or Holy Name Hospice to help families figure out, are you going to meet criteria for inpatient hospice, or are you going to meet criteria for home hospice? And if it is going to be home hospice, how can we make sure that you're going to be able to provide the care at home? Most families will kind of follow the lead of their doctor when it comes to hospice. So you may be, like Ronnie said, moving forward with your treatment. There comes a point where you're getting your treatment that you're not improving. It's difficult to make, to know when do you stop trying to treat and change over to comfort and end-of-life care. Sometimes doctors are a little nervous, like Ronnie was saying, to suggest hospice because they have their own, they're invested in helping you to get better. And if they're not helping you get better, now they feel a little bit, like they failed, or, they're not pleased to give you the bad news. So sometimes for families, doctors won't bring it up, but if you bring it up, I don't know if some of you might be taking care of elderly parents or spouse, siblings. If you've had an experience where you see someone is getting treatment, cancer, CVA, kidney failure, whatever the disease is, you might start to question, is this treatment helping? Should we consider something else? And the something else is usually comfort care, end-of-life care. You can bring it up to the doctor. Sometimes doctors wait for families to bring it up because they don't want to be the one. And then you can have a referral sent. I would go out and meet with the family, explain how the benefit works, do the evaluation, and if you're able to come to Villa Marie Claire, it's a beautiful facility. Like I said, it's the only one of its kind in Bergen County. Most people don't know about it until they need hospice, and many families that come, their one complaint is that they wish they knew about it sooner. So that's why we try to come out and really educate the community. It's literally 10 minutes from here, where we live very close. It's 20 private rooms. It's all 24-hour nursing care, so it's the same level of care that you get at a hospital, 24-hour nursing care, 24-hour aides. Our doctor, Dr. Charlie, he lives at the facility. He oversees all the care once patients are admitted, and he's there daily. Family and friends are welcome 24 hours a day. So if you have a family member who's a patient at the villa, you can stay at the bedside. We put a cot in the room for you. You can stay in a guest room. We have guest rooms for family members, and there's no charge for that. Certainly, you can also come in if you're considering hospice for someone. My card is in here, and so is Dr. Bialotti's. You can call me and ask me questions. I can meet with you, just give you information. You can tour the facility. Some families start at home knowing that once it gets to a point that it's not going to work out at home, they're going to transfer to the villa, and I can help with all of that. So I am the only liaison for Villa Marie Claire, but my cell phone is in here, and if you knew someone or you needed more information about how hospice works, you can always call me. I answer the phone anytime, all the time, weekends too. So just to show you what we're passing out is the brochure for the villa, and then home hospice as well is in here, and some information on palliative care, which palliative care is comfort care. The other misconception is you can get palliative care without being on hospice. So you can get treatment for your cancer and also get palliative care. Okay, that means you're getting better symptom management, so you're not suffering from your treatment. But hospice care is only palliative care, no more treatment. So there's some information about palliative care and how that helps patients, to truly live the best that they can in spite of their terminal illness. So I want to give Dr. Bialotti a chance to talk as well, and I'm not sure what time it is, but take a brochure, the folders, and... Okay, thank you. We want to leave time for questions.
Thank you. thanks very much for the opportunity of meeting with you. You know, all too often people think of hospice as a program that's dedicated to providing people with death with dignity. And that's important, but death is just a moment in time, and what our focus is really providing people with life with dignity. Wonderful conventional treatment, be it dialysis or chemotherapy or radiation therapy or organ transplantation and antihypertensive medications are beneficial and wonderful and helpful, but at some point when our bodies begin to fail, they become toxic, they become futile, they become useless, really, and they wind up with patients coming in and out of intensive care units from the toxicity of the treatment rather than the illness itself. And by shifting your focus from disease-focused treatment to treatments that are prescribed because they can be given for a particular illness, to a focus on people-focused treatment, on comfort care, on dignity, on life with dignity, you really prolong people's lives, you decrease the cost of health care, you allow people to live a better quality of life. And what we do is we don't embrace just the patient, we embrace the family as our unit of care. So everyone is embraced, everyone is brought into the care process, everyone participates in the decision-making, in the focus of the care, in the location of the care, and in the changes that are necessary. But by no means do we stop treating people. The care is actually more intensive than it is in other situations, but it's focused on the person, on the human being, on the individual, trying to give them what they need, what they want. And we very often have this thing they call the conversation. And the conversation isn't, you know, you've got terminal cancer and you're going to die in 3 months, so you really should come to us. The conversation is really, what do you understand about your illness? How do you feel about how your treatments are going? What would you like to see as far as your health care going forward from now? How can we help you better to live a better life? How can we help your family to cope better with what's going on? And those answers help guide us in offering patients what they need. And it's just amazing how people embrace the concept once they understand what it's really all about. It's not abandonment. It's actually refocusing and re-embracing people. And it's living there has been the most rewarding experience I've ever had, because you find that people come to you at a desperate time in their lives, and they leave with a much more positive attitude, a much more positive remembrance of their loved ones' last weeks or months than they would have had if they had them in an ICU, which is impersonal and sterile and isolating. But if they're in an environment where they can live and be together and understand that they're comforted, and the patient also benefits from knowing that their family members are going to be supported with bereavement counseling at no cost for 13 months after a loss. They know that their families are not going to fall apart. We try to reassure them that the life that they've created, the legacy that they've created, will continue once they've left. So that it's really a very, very different concept of end-of-life care. I've been doing hospice since the late 70s, and the change in what we can offer people, the change in the medications, the change in the opportunities and the options is enormous. And the villa is probably the ultimate opportunity to experience life with dignity. We had one woman there for 408 days. We have had many 6, 7, 8, 9-month residents. We've had people who have passed away. One lady in 3 minutes, somebody else died in an ambulance on the way there. But this is the tragedy of late referrals, because either the doctors can't admit that the disease is winning, or the doctors don't have the right conversation with the families and with the patients. And then people are left without that comfort, without that. I personally have had that awful experience. And it's it's a pain, it's a sadness that never leaves you when you feel that your loved one hasn't been comforted, hasn't been supported, and when you're not offered the opportunity to improve. So that's what we offer, available to anyone who wants to speak with me or come and tour the villa. We work together as a team, and it's a very special team of people who get great pleasure out of seeing people recover. And I've had many, many dinners, mostly with men who've lost their wives, and I don't know if it's a similar connection or whatever, but one night 12 of us went out for dinner. We're not talking about death and dying, we're talking about life and recovery and healing, and it's just it's a wonderful way to look at changing the focus of your care as you approach the end of life. Questions, please.
I have
Yeah.
one. So